I'm Nabil Nizamuddin. Now, our next speaker is an old friend and my ex-boss, Timothy Pruett, Dr. Timothy Pruett. He finished his medical school from Texas, Houston, and he had a very long training, and he has been a board certified in 1982 and then 84. He's got a long academic appointments as well, but the longest period he spent was in University Hospital UVA in Charlottesville, Virginia, for more than 10 years now. He is in charge of the in University of Minnesota in Chief Division of Transplantation there. Now his talk is going to be on something interesting too. It's a balance of likelihood of morbidity from disease acquisition against that of disease progression, of the disease that makes the waitlist patient a candidate for organ transplantation. I think that's correct, Tim.
Wow.
Well, please proceed.
Thanks, Nabil. How do we get this up to go up? My talk today is going to actually be on donor-related risk factors, but that's okay. It's close enough. I want to thank the organizers for the opportunity to come. It's great to be in Saudi Arabia with so many friends and trying to figure out how to run the system. Dr. Delmonico made a very important point about the shortage of organs that we have in our country. And I'm going to talk about the other side of what our system is. And that is the system of safety. And every industry in the world has hazards to it. And as you can see here, when the birds get in the jet airplanes in the US, we had a plane come down and land in the Hudson. There are things that happen in organ transplantation which can affect the really tremendous outcomes that we want. Organ donation is supposed to be a good thing. Organ donation is supposed to help others in need. And you can see from the National Health Service in England their card that says, "I would like to help someone to live after my death." And there's a tremendous amount of excitement that people get when they receive the gift of life. But sometimes, as you all know, a gift is not always what it appears. And there's the very classic story of the Trojan horse, in which not only was it not exactly what it appeared, but at the time when everyone was asleep, you can see that the outside of that gift and outside of that horse crawled an invading army which took over the city and completely changed the outcome. So that the unexpected can happen, and it can happen in organ donation and transplantation. This was a story that appeared a couple years ago in the United States, in which the downside of organ donation was described. And I'll just want you to look at the first line, which says that the kidney transplant was supposed to be the gift of life, but ended up taking it away. And under this circumstance, the recipient receives strongyloides, as well as a kidney transplant. And there are a whole host of different things, and I know that every one of you has been involved with some sort of story about a recipient who received something that they didn't want. So let's drop back and let's take a quick look. People die and become organ donors. That was Dr. Delmonico's story, and these people have all sorts of different functioning kidneys. But not only do they have different functioning kidneys and different functioning organs, they also have had some things happen to them during their life that may be that the recipient does not want. Infection is pretty common in the world. This is not to be memorized by any stretch. It just says that a large percentage of the US population, and oh, by the way, a large percentage of the Saudi population, a large percentage of all the countries in the Gulf, have been exposed to different infections. Now, they're different than what we've had in the United States. The most common thing that we look at in the US is CMV, EBV. Hep B is a much less common problem in our part of the world than it is here. Hep C is about 2% of our population. We have about 1 million people infected with HIV. Toxoplasmosis is about 25%, and it kind of goes on and on. There are a variety of different things which are in the population, and when people die, those diseases, pathogens, infections, however we want to call it, and there are important semantic differences, are inside the donor population. Not only that, but if you look at the people who die, and particularly as we age, our likelihood of developing cancers goes up. This is an old slide from 2005, but you can see that in the U.S., again, we have 2.5 million people who developed breast cancer every year, 2.2 million people who develop prostate cancer, and it just goes down. What I want you to look at is that where the kidney sits down there as the low number at 0.28 million, 280,000 new diagnoses a year. Wait till we show you some of the data about what diseases we recognize in donors and how many of these things we currently miss. So the real question is, how do we know what's inside? What we want is we want that little guy inside the Trojan horse to give himself away, just like they do here. Surprise! Let somebody know that you're there and to do it. Now, how do we know? Our current way that we know is really limited. So we do two things. This is out of our policy in the U.S., and I'm pretty sure it's policy almost everywhere else in the world. The first thing you have to do is somehow or another determine whatever conditions may influence donor acceptance. And that is predominantly to obtain a history and to review medical files, to try to make some sort of assessment as to who does it. Now, the question is, who does this? I mean, to go looking for the signs of lymphocytic choriomeningitis in a donor is pretty sophisticated stuff when the person who is the potential donor coordinator may not have those skill sets. So that the thresholds that we set on people to do these things is going to be quite different depending on how we go forward. Then the next thing to do is to perform a physical exam. Well, performing a physical exam by itself is pointless unless you're going to do something with the examination. And that is to either make a diagnosis or, in this case, is to make sure that the information is available to the transplanting people in order to deal with it. After we do those things and we make some sort of general assessment of this, then we end up doing a series of blood tests. And you can see the tests that we currently mandate in the U.S. And how we go through. The anti-HIV or HTVL1 and 2 is no longer available in the U.S. For routine early turnover kind of thing, and it's been dropped off that list. So the processes are awkward, and we're undergoing quite a few changes. Routine questions need to be made regarding medical and social history. In the United States right now, we're undergoing a transformation because the tissue bankers and the blood bankers and the organ bankers all use different history and physical. And the questions which we ask of the recipient family, or the donor families, oftentimes is quite heterogeneous. So we're now trying to move towards a uniform donor health questionnaire, that UDHQ or whatever it's called up there. Whether or not that actually ever really becomes implemented in our country will be unclear. But the premise is that we want to try to find a routine, uniform way to make sure that we cover all of the major areas. Recently, about 2 weeks ago, the Public Health Service in the United States, through the CDC, released for public comment an updated version of the, if you will, the high-risk behaviors and people who would be for organ donation. What is not known, however, is something really clear. How much does the historian actually know about the donor, and how much credibility can be given to that history? There's no way for us within our system today to say that the historian is actually a valid historian. In a medical record review, how well can the reviewer understand the prior diagnoses, interpret the path reports, and the rest? In the latter case right down there, there was a fairly recent case in the United States where Balamuthia was transmitted to a recipient. And very clearly in our system, it said that at the diagnosis, at the time of death of the child who was the donor, was that whatever caused that child's death was not transmissible. Clearly a lack of understanding of where we go. So that everyone has personal secrets. We all have, in the U.S., we have this phrase, skeleton in the closet, where we have things that we don't want the rest of the world to see. And in fact, the rest of the world needs to see the factors that the donor brings to the organ donation story. So we have to somehow or another find a way to make sure that all the skeletons in the closet of organ donors get known so the recipients don't suffer. One of the things which happened after, there was a very famous case in Chicago 4 years ago now, in which a man died and was tested and found to be negative for HIV and Hep C, but gave HIV and Hep C to a series of recipients. And the Organ Retrieval Agency in Chicago went back and looked at what they did afterwards, and they came up with these issues. Now this is just for those of you who don't know, this was the old, actually the current high-risk guidelines from the CDC, so that when we end up looking at our donors in our country, we say, aha, you're a high-risk donor, you've had these exposures, and you can see clinical findings of fever, weight loss, et cetera, male homosexual behavior, IV drug use, and it kind of goes down a list of different things. And what we found was that, in fact, if you can see in the middle line, it says, actually the total on the left-hand side, there are about 3,900 total donors. 14% of the donors in Chicago were high risk, and 86% were not high risk. Surprisingly, high-risk behavior goes with being a male. Does that surprise anyone? Guys tend to go out, and we have a higher risk behavior than women. It's more likely to die from a traumatic injury, from brain death. It's more likely to be of an ethnicity, particularly in Chicago, where there was more gang behavior. And so that the high-risk behavior, the high-risk group was younger, male, and more likely to die from trauma. And what they found was that in the history component of how people got to be high risk, what was the most common cause? If you look down there at number 7, the most common thing that was the high-risk behavior was, in fact, not behaviors, but it was the fact that they were in jail, that they had been in jail. It was the thing which couldn't be hidden from anyone, which was available for a public search. The behavior patterns which would be of curious behavior, which is sexuality or IV drug use, actually constituted quite a low frequency of identified reasons for being labeled a high risk. You can see that in the high risk behavior, HIV was pretty uncommon, and it actually turned out to be the same frequency as in the non-high risk behavior. HBV was the same frequency as the high risk behavior. Hep C was the only one which was much more commonly identified with high risk behavior. Core antibody with prior was also a little bit higher in high risk, people who are identified as high risk. This is just a way to reconfirm that whole thing. The only difference between high risk and non-high risk on serologic differences truly was in the Hep C relationships moving forward. So the history as we know it is really a very uncertain deal. There are too many unknowns for third-party historians. It needs to be done. It needs to be taken thoroughly. Positive elements do need to be taken seriously, particularly geography, people who come from areas of endemicity of certain parasitic disease. However, there should be a lot of skepticism that regards the reliability, and standardization of questions may help, but we're still not sure exactly what to do. Now the next question I want to go to really quickly is the laboratory evaluation. This is very dependent upon your area, pathogens and their environment and geography dependent. Age is also dependent for risk. The regulatory bodies will determine a great deal of the types of tests and the adequacy of the specimen to be tested. This is one of the big issues which is going to be coming up in our new high-risk behavior document coming forward. And the tests must be performed and interpreted in a time-sensitive manner. So, but the question is going to be, what will be done with the tests? Well, you got to look at them, first of all. One of the big issues which has been occurring nationally and internationally has been getting a test and not looking at the result. And so you can just see in several different examples I've come up with. In August of this year, there was a case in Taiwan where there were a number of organ transplants performed from an HIV-positive donor. The donor was known to be HIV positive going into it, but people just misunderstood the coordinator when they said that, in fact, it was an HIV positive. It is part of the problem with communication. In Taiwan, they were using voice-to-voice communication and phone and not documentation through a standardized nomenclature type of thing. Then there was a case in Pittsburgh where the transplant team ordered a hepatitis test and didn't see it before they did a live donor kidney transplant and gave hepatitis C from a donor to a recipient. Again, not that it was not known, it's not that it wasn't available to be known, but it just wasn't known because no one looked. The consequence was pretty significant, where the surgeon was demoted afterwards. And then the CDC recently reported on the HIV transmission of an organ donor in New York, again a live donor, where the HIV was done pretty far in advance, about 3 months before, 2 to 3 months before the person then partook in high-risk behavior and then gave HIV to a recipient. And that is going to raise the question of when is the sample, what is an adequate sample, both in terms of quality of the serum as well as time from the time of assessment to donation. Clearly, in deceased donors, it's very easy. The person is dead, you have a very short window, the dead person can't do any more activity. Whatever you assess is what is done at that time. Whereas living donors, depending on when you assess it, there can be a lot of behaviors and changes in acquisition of disease which occurs afterwards. So, there are 2 different take-home points. One, the center has to verify that someone's looked at the results. This is a safety issue. This is akin to making sure that the ABO is consistent with the donor and the recipient. Many transmissible diseases, however, are acceptable. We know there is infection in many, many people that we then transplant. CMV, EBV, hepatitis C for hep C recipients, core antibody positive organs. We routinely will transplant those. But we must make significant attempts to avoid giving diseases to recipients for which they're totally unaware and unexpected. However, we have to recognize our systems. We cannot be 100% successful. So in September of this year, the CDC, like I said, released its current guidelines for the prevention of reducing transmission of HIV, HCV, and HBV through organ transplantation. In this, it's out for public comment. It has not become our policy in the U.S. yet. But it mandates that we do both NAT testing and serologic testing for HIV, Hep B, and Hep C for both live and deceased donors. They describe the adequacy and the currency of the sample that must be tested. And there's little discussion subsequently upon the impact of the expanded core categories of testing upon organ availability.
Tim, we are running short of time.
Okay, I'm done.
Yeah, okay.
This is just to say that it's fraught with issues, and that biovigilance is a new buzzword which is here to stay. It's a necessary function, and it will affect the way you practice transplantations. It's not a bad thing as long as we keep appropriate confidence limits inside and incorporate it. Thank you. And sorry about going over.
Thank you very much. That's very nice and elegant as usual. And it seems that we don't have time for any questions. Probably we'll leave it till the end. we can go for the next speaker.
I would like to